Vamos a arrancar con innovación quirúrgica en trasplante renal. Ese es el bloque que tenemos hoy. Bueno, como ustedes, hay mucha gente que está acá que no necesita ya presentación. Hoy vamos a tener una primera presentación del Dr. Alvin Wee, que para nosotros es un honor. Es el jefe de trasplante renal y renopancreático de Cleveland Clinic. Ayer estuvo operando con todo el equipo y la verdad que su entrega es maravillosa. Welcome, Alvin, to this meeting. It's really a huge honor to see here.
So again, thank you everyone. Gracias, muchas gracias. I have my phone, so some Spanish words I have to say. So thank you, Rafael. Thank you to the whole clinic, Veles Sarfield, who invited us. We're very grateful. We're very honored. And I think the most important thing I've seen is that we want to thank you for your hospitality. Coming here always make me, it's a humbling experience. It's also keep us grounded, that because it always makes us learn that we can learn from each other. And not just because we're at Cleveland Clinic, we know everything. That is not true. We're here to learn too, and we want to get better. So really thank you, everyone. So let me share to you my experience. Now let's go to the topic now. Let me share you our experience about robotic kidney transplant. I know that people now, even me in the past, right? About 2017, 2018 robot, my first reaction will always be like, really? Like all these things, right? But as I said, time, the only thing that is constant is change, right? Is change. Let me tell that in Spanish, so just in case people don't understand that. Let's see. Yeah. El cambio es constante. Okay? Think about it. So let's go first, okay? Think about donor nephrectomy, right? When we donate our kidney, right? Donate, right? As of now, as of today. Oh, sure. You want? I can come up here. That's fine. Yeah. Think about it. When we talk about it, right? This was the standard before 2000, year 2000. Before 2000, when you say about donor, open, cut, open. That's the standard, right? And then around 1994, 1995, also Cleveland Clinic was starting to do it. There was a lot of criticism, okay? They say, oh, crazy. That's why, it's true. There were a lot of criticism, right? Because why are we doing this? Donor, we what do you call it? You cannot take the risks, why are we doing this? But in the 2000, it's almost the standard now, right? It's almost the standard. In fact, I was saying that la técnica abierta es casi desconocida en los Estados Unidos. You don't hear it anymore. I mean, here rare, even here, but even here, everybody's adopting, right? So, how about robotic donor? Is this going to replace laparoscopy in the future? Maybe, maybe not. But let me tell you, it's possible. Posible. Why? I'll show you why. So, when we talk about robotic kidney transplant, okay, it started around 2014. Some people were describing it, all these things, right? And there were increasing in numbers. Other centers in the world or in Europe, they do this, they do that. And then in the United States, the two pioneers were the Henry Ford and the UIC. Okay, they started doing this even as early as 2015 by Manny Menon, Henry Ford, who is a urologist. They tried to do this, but change is very difficult, right? Everybody is comfortable of where they have been, right? They're very comfortable. But change is constant. As I said, change is constant, right? So when I just to show you how difficult it is, when I came back to the Cleveland Clinic in 2017, so the urologists, they use robot, right? We use robot, but nobody talks about transplant robot, nothing. But I saw the usefulness of it. Why? Think about dual transplant. Transplant with 2 kidneys, right? From deceased donor. I said, just imagine, we can make 1 incision, put 2 kidneys, and put it all together, instead of doing 1 big incision. Maybe, right? That's the usefulness of the robot, right? And I said, we should do it. We should do it. Even our previous chairman was telling me, no, you should not do it. My previous chairman at Cleveland Clinic tell me, no, don't do it. Because, you're gonna get the robot from someone else. So you can see there's a lot of, this is nothing new, right? And even my predecessor, my boss, you talk to them about robot, oh, crazy. Let's do all open. That's how it is. But I said, there's going to be some role in playing it, right? So, but this is the intraperitoneal multiport, in which there's like multiple holes. So, because of that, us, Cleveland Clinic, said let's do something that nobody has ever done. And that one was the one that I showed you last year, right? The single port, right? We did this in 2019, the first one in the world, right? First in the world, this was extraperitoneal, outside, afuera, barriga, right? Outside. That's what we do with open, right? So this is the first in the world we did, right? So when we talk about robotic kidney transplant, we talk about multiport, which is adrento de barriga, or single port, which is extraperitoneal, right? It's extra. So what are the advantages? Of course, we saw that the extraperitoneal is the gold standard, right? It is the gold standard. The patient is just flat. No need to make upside down like that. Just flat. And the cosmetic, just 1 incision. Less pain because we don't really cut muscles. And it's really quick. How did we learn it? How did we make this rapid approach? Okay? Simple. So let me show you the limitation first. Of course, the space, very small. And the lymphocyte, right? Just like open technique. So the way we learned this approach is because we were fortunate, the orthopedics, I know, the neurospine, they asked us to expose this to them, the spine. You see the spine. They asked us, can you help us? Can you help us? Can you help us expose this? I said, okay, let's try. So we learned from it. And then we found out, we can do the robot like this. We'll use our hands to expose it. So it technically takes us 10 minutes to reach there, 10 minutes. Then we can bring the robot in, just 10 minutes. So it really made very easy. It really made it very easy. So let me show you our experience. Now let me share you our experience. And how long did it take for us to adopt the robot? So this is the number of transplant that we've done. Total number of transplant, right? In 2024, last year, we did 356 kidney, 356. And this year, we've done almost 160 already, okay? Look at our robotic transplant, look. On 2019, only uno. 2020, 5. 2021, 8. 2022, 16. Then you see 24, jump. And 2025, as of today, we've done more than 50. We already done more than 50 robotic. 50, 50. And it's only May. Okay? But it took long, very long. And this is to show you between deceased and living donor, right? So you see, the problem is we only have 1 SP, only uno in the whole Cleveland Clinic. So that's why it wasn't helping us. Because we have to wait. We only do it in the weekend, okay? Because nobody's using the robot. So you see, we do a lot of deceased donor. In fact, in terms of deceased donor, we are the number 1 in the world. world in terms of the experience in the robot. We are number one now in the world, even bigger than Europe. Europe is do a lot of living donor, but it's all combined, like 15 centers. But a single center, uno institution, we are the biggest in the world. And last year we did a total of 61. See, 61 total. 61. Last year, 61. And this year we already reached 50. And just to show you what have changed, living and disease. So this is the difference, see? SP and XI. See? The problem is SP, SP1, 1, SP, 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 then all XI. Why? Because the XI, we have 7 XI in Cleveland Clinic, but we only have 1 SP. That's why. That's a problem.
Let me interrupt you.
Yeah.
SP tiene un solo, una puerta, y el XI es múltiple. Tiene 7 robots, pero uno solo de los 7 está limitado en la cantidad de personas que puede hacer con un solo robot.
Okay? So, see, it's an availability issue. Okay? Availability. Okay? So you see, it took 5 years to grow. 5 years. We only start 1, but look, 5 years. Now, just to give you an example, last week I was telling Francisco, I was telling Miguel, telling Luca, last week, May 11 to May 18, we did 5 living donor, 6 deceased donor. 9 of these 11 were all robotic, and 2 was only open. I was joking that our resident is getting mad because they don't know how to do open because we're doing because we want to get better, right? So they're getting mad because nobody is doing open now, you see? And yet, before I flew, we have a patient with BMI of 41. Easy robot, easy, very easy. Because it makes it easy, right? Just to show you here. So just to show you, so this is a multi-port, just quickly. See, it will be quickly. See, that's the kidney. We just shoot it there. Put it back. You see right there? That's the artery, the vein. You see, very minimal. Dissection, very minimal. Only very minimal. Even on patients who are on dialysis for 6, 7, 10 years, where their bladder, what is a bladder here? What's urinary bladder? Huh? Yeah, they're small, right? For 7, 8 years, it's almost very small. It will be very easy for the robot because the robot will put it on top of the, oops, I did go back, sorry. Wow. How do I fast forward this anyway? But anyway, this is what happens, see? We only have one small fan steel and then the four of that, right? If you think about it, right? Okay, hold on, let me just, okay, anyway. So just to show you our Cleveland Clinic population, this is about a year ago. We compare, right? This is just to show you the difference. So it's no big difference. Actually, our people who are on the robot are bigger, okay? And you can see with time, and also this, Francisco, I wanted to show you, see? Look, the operation when we started was about 4 or 5 hours in 2019, 4 or 5 hours. Now we're down to almost 2.5, 3 hours. Okay? And this is the sewing of the blood vessel, the connection. From about an hour to 30 minutes. So the same as open, 30 minutes, it's the same, right? It's the same. See? It has come down. And even the XI now, you can see, is down to 30 minutes because it's the same, right? Just to show you the outcomes different. So this was the extra. But anyway, I wanted to show you the difference we notice is the multiport about higher ICU admission. Why? Because think about it. They're like this. The head is down like this. The patient they're like this. So if the patient is big, they're like this. So the water, everything is in the lungs, right? So that's what we notice. Like that guy, BMI 41, went to ICU, you see? But only overnight, but tomorrow they're fine, right? And then showing you living donor versus open, it's the same. Actually less pain. Blood loss is minimal. And again, between, what do you call this? Yes, less post-abortive pain compared to open. And look what we have done after 5 years. Look what we have done. So 2019, we did the first extraperitoneal kidney transplant, right? We did the first robotic dual transplant in the United States. India did it first, but we did the first in the United States. Two kidneys. We also did the first dual, 2 kidneys on the same side, up and down, 2 kidneys on the same side. We use robotically. So think about it, that small incision, you just drop the 2 kidneys, sew it, it's finished, right? We did the first robotic pediatric, right? First robotic pediatric transplant. Actually, we already did 2. Well, they're about 15 years old and the other one was 16, something like that. They're still big like this, but still, it was a single port, you know? And they're very happy because it's very small incision. And we just did our first kidney pancreas this January of 2025. You think about it, kidney pancreas, we usually do, but now, small incision and then the 4-hole. Big difference. So, therefore, my conclusion is robotic assisted kidney transplant is an alternative approach to open, right? But will this be the future? Probably, right? Because the patent for Intuitive, which is the Da Vinci, is expired. So it means now a lot of robot can come and, you know, Francisco was saying we have from Korea, from China, from India. I mean, there's a lot of robot now, right? So it's just a matter of time where the cost of the robot will become so cheap. And even look at our residency training. I was telling Francisco, residency training. Nobody's teaching them laparoscopy except me when we do the donor, but everybody's doing robot. And remember that in the first slides I mentioned to you why I think even donors, they will do robot? Because nobody's teaching them how to do laparoscopy. So then they only know how to do robot. So everybody's doing robot. And to me, it doesn't make sense to do multi-port donor because you have 5 holes. Where laparoscopy, you can only have 3 holes. But they don't know. They don't know anymore. Nobody teach people. And this was within our conference about a few months ago when we were talking about the robotic. One person came and asked, oh, why spend a lot of money on a robot to teach the next generation when laparoscopy is cheaper? You know what was his answer? His answer was, well, nobody's teaching laparoscopy now. Nobody. So every young generation are being trained on the robot, so we have to teach them how to do it. Not because, you are right, laparoscopy is cheaper, but nobody's teaching this to new people now. So that's the problem, which makes sense. And that's the reason why, like for me, I have to adapt myself, right? I have to learn the robot, right? Because even though I was not in that generation, I was in the generation of laparoscopy, I have to adapt, right? That's why our donors now, we do SP, so I have to be 1 step ahead, right? The robot. And now it's so funny, every time when we get a kidney transplant, because we got 2 new robots, that's why we have 7 robots now. They always ask us, oh, do you guys want to do robot? Do you guys want to do robot? Do you guys want to do robot? It's like the robot now is the standard more than the open. And if I don't learn how to do it, then soon I won't be able to do, I don't know how to do transplant because everybody's doing robotic. So, again, it takes time to build the momentum. Again, just to share with you guys, it took about 5 to 6 years before we really get that momentum. And of course, there's definitely several advantages over open kidney transplant. I think that's all. Thank you.
Bueno, la idea es, bueno, después de la excelente presentación de Alvin, es poder charlar un poco más entre nosotros y aquellos que tienen más experiencia. Hay muchos cirujanos acá. Si realmente esto es una utopía para Latinoamérica. Creo que todo el camino va enfocado, como dijo Alvin, hacia allá. Les dejo acá a los cirujanos para que puedan compartir aquí.
Gracias Rafa, buenos días a todos. Good morning Alvin, congratulations, it's always a pleasure to listen to your lectures. You are not only a great surgeon, you are a great human being. Thank you for your time and to be here, and thanks for the opportunity to share surgery and time in the world with you. So it's a really nice experience. The first, as a laparoscopic surgeon, I'm really convinced that minimum-invasive procedures, it's the way in the actual time of surgery and the future. Offers two advantages to our patients. So I think that robotic surgery is the future of surgery. For us, the first question I want to ask you is how we can start. What's your advice for us? If, for example, tomorrow we can buy a robot, how we start? How we select the first case? How is the learning curve? How we train for that?
No, that's...
Perdón, sorry, le estaba comentando al doctor Wee que como yo soy cirujano que hago laparoscopía, soy un convencido que la cirugía mínimamente invasiva le ofrece muchísimas ventajas a nuestros pacientes y que el camino, el futuro en la cirugía tiende a la cirugía robótica, como muestran todas las publicaciones en el mundo que hablan que la laparoscopía está en vía de muerte o desaparición y que el camino es la robótica. Y la pregunta que le hice al doctor Wee es: si nosotros pudiéramos tener hoy en día un robot, ¿por dónde empezamos? ¿Cómo es la mejor forma de hacerlo? ¿Cómo elegimos el primer caso? ¿Cómo nos entrenamos para eso? ¿En qué momento? Y cómo empezamos la curva de aprendizaje, y si hay una, ¿cuánto dura?
So the nice thing about of course, if you guys, let's say you got the robot tomorrow, the first is to find a simple case, right? When you say simple, is the anatomy is straightforward, right? Like the blood vessel, vena, and the arterio, limpio, right? And then from the kidney that comes, also uno artery, uno vein, right? But the nice thing about the robot is that there is a model, right? So I was telling Francisco, because Francisco is very, very good in laparoscopy. And I said, if you are very good in laparoscopy, robot will be easier for you, because robot is just understanding how to use it. It's like another tool, right? It's another tools. It's not like it's hard, no. To tell you the truth, people who knows how to do laparoscopy do better with robot than the other way around. If the people who does robot, you ask them to do laparoscopy, they don't know how to do it, because they have so many arms they can do. But if you know how to do laparoscopy, it will be very easy to do the robot. Until you learn, it's really more of troubleshooting the robot. Like, okay, my arms is fighting each other, what should I do? But the nice thing is what the Europeans has shown is that they have these models, and I was telling Francisco that once we finish that model, he can get one, and you can use that robot to practice on that model. okay, like a real model, but three-dimensional model. You practice the sewing, and once you become, what you call this, you become comfortable with it, then you can do it, right? Because Francisco, he already know how to sew. He just need to, instead of using it like a stick, he's gonna use now an arm how to use it. That's really much it. So, in fact, robot is easier to learn than laparoscopy, if you ask me. If you ask the resident, it's easier for them to learn the robot than laparoscopy.
And why is that?
Hmm?
Why is easier?
It's easier according to the resident is because, number one, your vision is very, very clear, right? It's very close and you can move like this. It's not like, you see, when we do laparoscopy, I have to tell Manuel, show me that. Manuel, show me that. Show me this. Show me this. But with the robot, okay, I want to see this. I move the camera to here. I move the camera to there. I move the camera to there. And then there's a lot of arms, right? The XI has a lot of arms. Laparoscopy, you only have those two arms, right? So you have more hands inside to help you. And there are things that the robot can do, like you can twist like this, the arms, but laparoscopy, I know they're changing it, but it's always straight, right? I know there's some flexible like that, but it's a little bit unusual to use that. But robot, it becomes like whatever you like, right? Because it's like the hand inside instead of just like a stick. So it's easier for them to adapt because, and they can always learn it in the laboratory with the 3D model, like try to sew, like all those things. So it's easier. And also remember, in robot too, there's a dual console. There's a console, you know, him and me. So student, let's say for example, student, me. Okay, I'm here, you're there. Okay, so I give it. Okay, Francisco, you do it. So Francisco doing it. No, don't do like this. I'll get it from him, then I'll do it again. You see, laparoscopy, I have to stop. Okay, get me. You keep on exchanging it. But there, robot, I can teach you at the same time because there's dual console.
Hay un comando dual, digamos.
Yes, commando dual. Yes, I can show the other one. So you're seeing what I'm seeing. And I'm showing you how I'm moving, and then I can let you do it too at the same time. Like the switch, keep on moving. Switch here, switch there, switch here, switch there. So it's easier to train them that way.
Okay, thank you. Another question, when we are listening your lecture, you are talking about your learning curve from the first cases to until today. And you show that at the beginning, your anastomotic times were longer than 1 hour, 60 minutes. All published data shows between 60 and 90 minutes in the first robotic cases. And today you are in 30 minutes. That's
yeah.
fine.
Muhammad, yeah.
When we were trained as transplant fellows, everyone here learned about you have to sew quickly. You have to take less than 30 minutes.
Less than 30 minutes.
For not generate an impact on graft survival. So the question is, what do you think when you are starting in a robotic program, that prolonged anastomotic time has a real impact in graft survival? What do you think about that? That's the first question. And the other one, there is any difference if you use a DVD or DCD donor? Because the graft, you are putting the graft into the peritoneal cavity, and that graft make heater that maybe be attacked for the heat of the body, for the temperature, and the CO2 even get pressed that graft. So do you think that have a real impact? And sorry, for translate the question, le estaba preguntando al Dr. Wee, siempre uno de los problemas en la hora de la cirugía del trasplante renal son los tiempos de anastomosis vascular, en la que clásicamente todos los cirujanos se nos enseñó mucho tiempo que lo debemos hacer rápido porque el riñón sale de estar en frío y pasa a estar al cuerpo y debemos tratar de demorar idealmente menos de 30 minutos porque estudios clásicos demuestran el impacto que eso tiene en la sobrevida si uno tiene tiempos de anastomosis prolongados. Él muestra en el comienzo de la charla de que los tiempos iniciales al empezar a entrenarse en un programa de trasplante robótico, los tiempos de anastomóticos son de 60 minutos o incluso si uno ve la literatura pueden tomar más de 90 minutos. Y le preguntaba qué piensa de ese tiempo, si tuvieron algún impacto en la sobrevida de estos grafos, en los resultados. Y si era de la misma forma, era lo mismo usar un donante vivo o un donante fallecido, y un donante fallecido en muerte encefálica o en muerte circulatoria. Así que esa fue la pregunta del Dr. Wee.
So, in our experience, there's no difference. I'll explain to you why. Because we are a training institution, right? We are a training institution. We have residents, we have fellows. You have to teach them, right? We have to teach them. So even when we do open, I have to do half, you have to let them do the other half, right? As they get better, you let them do more and more, right? So even with that, it takes about more than 30 minutes. Yes, 30 minutes me, yeah, but you have to let them learn, or else how will you pass the trade, right? How will you pass the trade? So for us with the resident, usually when you do them the artery, you let them do the vein, it usually reach about 45 to 50 minutes. But we look at it, even my boss before, where they sew very slow, okay? It takes 1 hour to sew. That's why we were joking. When it's reached 60 minutes, I said, our previous boss was doing for 60 minutes, so what's the difference, right? So there's really no impact, I will tell you that. There's no impact, okay? Because the outcome, in fact, our outcome, the new batches, were much better than the previous outcome, right? So that at least can contest that. The second, about being cold or that. So in the initial phase of the transplant, we used to put ice on the kidney. Okay, when we put the kidney in, we'll put ice. That only delays the operation, makes the operation longer. But now, you know what? If you can finish it in 30 minutes or even an hour, it doesn't matter. Because, so we have a study now, we're doing a study now, in which we put a temperature probe on the kidney. We put a probe, like a needle on the kidney. Okay? We try to see, because some people say, oh, if you put ice, it's better, okay? If you don't put ice, not better. So what we did is, we're doing right now is to put a needle on a kidney with ice and a kidney with no ice, and see what happened, okay? The truth is, on the temperature curve, now these are very accurate because you put the needle into the kidney, you poke into the kidney, right? What we notice is, if you don't put the ice, is usually it will reach body temperature around 10, 12 minutes, 10, 12, 15 minutes, okay? So when you put the kidney inside and then you wait 12 minutes, it becomes body temperature, 25 degrees. If you put ice, that curve, instead of like this, it'll become like this. But it reaches 25 still. Because remember, you're only cooling the surface. You're not cooling the inside. So that temperature probe is very accurate, because even after a certain, I can't remember the minutes, it's still 25, even with the ice on top, because that temperature is getting the temperature of the inside of the kidney. So we're not done with that, but really in our experience, it didn't really show any difference in terms of the outcome, like you said, the survival. Of course, we only measure up to 3 years, so I don't know. Maybe 10 years, does it affect it 10 years, 20 years? I don't know. But at least in the first and the 3 years, it doesn't really affect the outcome. Yeah.
Okay, thank you. I have two more questions, but ¿alguien quiere hacer una pregunta?
Yo lo que veo, pasar pacientes, tanto que...
No, I want to make a question about the wound. Yo lo que veo que en general son pacientes obesos, le ponen
Fan steel.
abajo de la pancita,
Yeah.
y vos no le encontrás la herida, tienen que levantar la panza y es así, y no le ponen punto, hacen cirugía plástica. When you make the wound down there,
Yeah.
I noticed that for robotic, you almost always have kind of like plastic surgery closure of the skin. And
Yeah,
then there's
because-
only one line.
Yes. Think about it. Think about,
But
look at our
let me
belly.
ask you a question. Why
Yeah.
do you do that kind of like plastic surgery type
Yeah.
thing?
No, look, like me, I have big stomach, right?
Yeah, we know.
Grande, see, right? But if you think about it, our stomach is like this. right? And then here is flat, right? That's why you see the C-section, they do the flat here.
Yeah,
There's less
parece
fat.
una cirugía de cesárea. Es igual a la de cesárea, pero
So,
más arriba.
When you do open, you do it here. So this is where our fat is. This is where our gordo here, right here. But if you do the phanestil, it's here. Our fat is only until here, but here there's no fat. I mean, there's fat, but not this one, right? Yeah. So that's the reason why you can close it like a plastic, because less fat, less, even the big like this, but here it's flat, right? Because the stomach is like this. Yeah.
Le hacen cirugía plástica a la herida y a los bebés normalmente.
Una pregunta para Emilio, porque obviamente acá hay gran auditorio de nefrólogos, entonces I believe in you, Alvin, about the outcome of the patients, but it's very important for the nephrologists. What happened with the clinical outcome in the robotic patients? No sé qué opinas vos, qué experiencia tenés vos. ¿Ha habido alguna diferencia en lo que se ve en la evolución clínica?
No, but I don't notice anything clinically.
Clinically, I will tell you, there's none so far. With our more than 100 plus, there's none. So we will eventually look at people who are big. We want to see the DGF between big people on open and robot to see if there's really a difference. But right now, there's no difference. You have to just be careful, because some other institution, that, for example, like North Carolina, University of North Carolina, Wake Forest, they were telling us they started to do robot. Then after their 6 case, they thrombose their kidney. Then they get scared, So we were very lucky, because we have done so many already, and we don't have any thrombosis, none, 0. In fact, we only have 1 open conversion, only 1.
Yeah.
But the rest, no open conversion, nothing, 0.
There are complications. I don't remember having, the latest case,
Yeah, the bleeding, because there was 2 artery, but that can happen in open too, right? Yeah, I mean, we because we're doing more complex now, even 2 arteries, those arterial, we do it robot. We just have 1 last week that has some bleeding in it on the smaller artery, but that's pretty much it. But it has an advantage too, Francisco, because we retroperitonealize it, right? There's holes, so we don't see lymphocyte because there's hole, right? And although we've seen one, it formed at the back of the kidney. Lymphocyte. And the second thing too, what we notice, you see, when ureter becomes strictured, right? Sometimes you see stricture ureter. It's easy to repair, because when you use robot, go in again, you'll see the ureter is there, strictured. And you can just move the ureter and connect it to the new one. Easier. So, and even like people with prostate surgery, people with radical prostate and all those things, easy, because you don't need to go to the scar, you just put it on top.
Sí, este año la mitad de todos los trasplantes que hicieron son prácticamente todos robóticos. Not half, but 40% this year of all the transplants?
Well, if we did 156 and we did about 50, that's already 30%.
Un tercio.
30% already, about 30%. Yeah. And now I think the momentum, we will get the momentum really. I think this year we might really reach 30 to 50% all robot. And
even during the week, ¿no?
Yeah, because we have 7 XI now.
En un momento solamente lo hacían los domingos, los sábados y los domingos, porque tenían que competir contra las otras especialidades por el robot. Pero ahora hay 7 robots. Entonces pueden hacerlo en el resto de la... Now you can do it during the week until that robot is saturated, and then they will say, they're going to compete for the robot again with our surgeons.
The XI, well, I mean, we were fortunate because we got 2 more XI, right? The SP, yes, but the XI, we always have available. I mean, sometimes, like for example, next Tuesday, they said there's no XI. Okay, so we'll do open. But most of the time, there's like the Wednesday one, there's an XI available. So, okay, So if the XI is available, we do robot. If there's no robot available, we do open. But now there's more availability of robots, so we can do more.
Nosotros tienen que entender que son lugares especiales. Estamos hablando de una institución tiene 7 robots, porque el hospital no es la foto que mostró recién, ese es un edificio de 20, ¿no? Entonces son lugares muy grandes y con mucho acceso a estas industrias. ¿Is there any robots in Florida?
There's no robot. They don't do robot. There is a robot in Florida, but they're not doing it yet.
But there's a robot in Cleveland Clinic, Florida.
Yeah, only one. Yeah, yeah. But it's getting cheaper. I'm telling you. Even the intuitive, there's a lot of like model. Like you can lease it instead of buying it. You can lease it. Then you have to pay the supply. So they're making it more accessible. Remember this day. Today is what? May 23, right? 2025. 10 years from now, I'm telling you, robot is like, nobody talks about it anymore because it's as common as what we've been using like laparoscopy now. Really. 10 years from now.
How much is a robot, Alvin?
Huh?
How much is a robot?
Well, the intuitive, I think, because I know there's taxes here, but I know for us it's only around 1.8 million, but it's more expensive here because they have to pay taxes.
No, but the problem here is even if you lease the robot, because in some institutions here in our country, companies are leasing the robot, but you have to pay per
The
surgery.
supplies, yes,
And
yes.
The cost per surgery
It's
are
more expensive,
than
yes.
the whole transplant module.
I see.
So that's the main problem here in Argentina for the transplant community.
El problema, hay un modelo de negocios en el cual se hace un leasing del robot, donde se deja el robot en la institución y se paga por cirugía. El problema es que el pago de cada una de esas cirugías es más caro que el módulo completo de trasplante renal. O sea que es una de las primeras barreras en nuestro medio es seguir luchando por mejorar esos módulos.
But that's
I
now.
have two
Yeah,
two
but
more questions.
just to tell you, I mean, again, to interrupt you, Francisco, sorry to interrupt. That's now. You're right. It's more expensive. But think about it. Think about laparoscopy 20 years ago. Think about laparoscopy. You want laparoscopy, you have to pay more. You want open, you only this. So, no. Everybody open because it's expensive, laparoscopy. But now, nobody talks about it. Laparoscopy is like common. It's very common. Nobody talks about it anymore. Nobody talks about it, right? See, so it's going to be the same. A robot 20 years from now, the supplies is going to be very cheaper because they have to compete, right? You have the China robot, even Abu Dhabi, CCF Abu Dhabi, they bought the China single port because Intuitive didn't want to give them. They gave it to the Saudis. They didn't give it to the Abu Dhabi, so they have to bring in the China single port. So I'm saying it's just like people are adapting. That's all. Yeah.
Okay. The final question for you is, do you have experience in node surgery and in the transvaginal route for graft insertion? That's one. And the other is, this is a personal thought that maybe the role of robotic in kidney transplantation, I don't see the benefit in the donor.
Yes, you are
Compared to I think laparoscopy is the gold standard for donor nephrectomy. I don't see the real benefit. Even if you see data in donor nephrectomy, you have more worm ischemia time. The pain scores are really similar, and you increase too much the cost and the overall surgery time. So that's my personal position in donor. But what do you think about the recipients in the transvaginal route of insertion?
So the first question in the transvaginal. So for us in the transvaginal, we are trying to learn to do the single port transvaginally, how to do it, how to connect that kidney, right? There's still some technical thing that the new generation SP robot has a way to do it, because think about it. You go in and then you look to the right. You go in and then you look to the left. I mean, right? When you go in, then you look to the left because that's the blood vessel, right? Then you connect from there, like you're sewing from the top, right? It can be done. It can be done because we've done it on cadavers first. It's possible. There's no question. There's a possibility to that. But I don't think we are at that comfort level yet to do it real time. But it's in our mind to do it, okay? But using the single port platform, because if we perfected that, then it's perfect because you don't have any incision at all, right? But we are not that yet. We are not yet there. But I think that's going to be a possibility. And to your second question, I 100% agree with Francisco. Compared to on donor, laparoscopy has way big advantage over robot. There's no question about that. But the problem is, like you, Francisco, you teach your next generation. For example, I'm just saying you're teaching your junior. Me, I'm teaching my junior. But if you go to other institutions, so for example, Northwestern, they go to what big institution? UCSF, right? Or what do you call this? Mayo, Arizona. Nobody's teaching the next generation laparoscopy anymore. They're teaching them robotic. So, and I mentioned to you, the problem with robotic, you have 5 holes. For us, we only use 3 holes, so there's really no advantage, right? But it's only me and Francisco who's teaching the next generation. But the other 80% are teaching them robotics. So eventually, you have to go with the crowd, because eventually we're gonna lose like all this next generation. Let's say my hospital, I'm getting old. I'm gonna hire the next generation. I'm gonna hire someone else. Okay, we try, but these people don't know how to do laparoscopy anymore. They only know how to do robot. But we don't have any choice, so we have to let them learn to do the robot, because unfortunately we are the minority crowd now. Everybody is trying to learn. No, it's true, because that's the reason why I'm trying to advance myself in doing the single port donor, and eventually to go retro. So I'll be 2 steps ahead, right? So we have to continue, what do you call this, evolving ourselves, or else we will be left behind. And I always joke this, Francisco. When I came here to the United States in 2006 to 2008, I learned laparoscopy. I have 0 laparoscopy skills, 0. 2008, I learned laparoscopy. I was so happy. I was so good in laparoscopy. Then the robotic came in 2008, 2009. Laparoscopy was losing its flavor, was losing everything, right? Then I said, like, wow, every time I learn something new, it's dead. Then there's another new thing, right? It's like that, right? So I was saying, I'm going to learn the robot. I'm pretty sure by the time I'm so good in the robot, there's something new. But I said, by the time I can retire, I don't need to learn those new things anymore. Yeah.
Katy, the new generation.
Yeah, the new generation. Katy.
¿Alguien quiere hacer alguna otra pregunta? Sí.
Buenos días. A ver, el tema de la cirugía robótica, muy lindo. Quería saber el tema de costos. ¿Qué tipo de robot es? Si es el mismo que está en mi hospital actual, que tengo un Da Vinci, o es otro tipo de robot, y cuánto cuesta hacer este tipo de cirugía.
He's asking about
Which
his
robot?
institution has the Da Vinci.
Okay.
He wants to know if the same robot that it's the same.
That you use?
And
Yes.
Do you know how much money does all the robotic program cost? Per surgery? Do you know how much money?
So I can tell you this on the Cleveland Clinic system, okay? So they told us intuitive. So we have the Da Vinci, right? We have the Da Vinci. Although Hugo from Medtronics they started to do the FDA approval, so they started in our institution because we do a lot, right? So we were thinking, because right now, intuitive is they're the most advanced, right? So it's just like everything is there. Like you think about a car, right? Think about a car. So intuitive is like all these electronics, everything is there. You can do everything very smooth, Medtronic, it's okay. But you can turn it on, maybe there's radio, all those things. So we were thinking, but Medtronic is way cheaper, half, almost 50% cheaper. So we were thinking in the future, what we're going to do is the complex stuff, like transplant, prostatectomy, partial nephrectomy. Those you use intuitive, right? But for the other cases like hernia, gallbladder, nephrectomy, because you don't sew, anything that you don't need to sew, you can use the Hugo because it's cheaper, right? then you don't need to fight. But what they said to us when we ordered the 2 new robots, according to Cleveland Clinic, they said, if you can do 350 cases on that intuitive robot per year, you make money if you make more than 350 cases. So I was joking with them, if we do transplant 350, we already have 150 for them. All they need is 200 more. And 200 more, you can easily do it because we do so many cases every day. So.
But the cost, I mean, for us, for a kidney transplant, they pay the same money whether it's laparoscopic or robotic. The government, I mean, Medicare.
¿No? In Cleveland Clinic, I was going to tell them, you never know what the cost is because what they tell you, you don't know overall how much is it per case to use supplies and everything.
No, that's a very good question because, right?
Lo que les dije que el costo es muy difícil de... El trasplante el gobierno te lo paga igual, lo hagas a mano, lo haga con robot, lo haga con cohete espacial, no importa, le pagan lo mismo.
So,
Entonces, yeah.
Francisco asked that to me. So, when there's in United States, when there is a new code, when there is a new procedure, you can put a new code. So we put a new code for robotic transplant. Now, just because it's a new code doesn't mean they're gonna pay you more, right? That's two different stories, right? So we have a new code now for robotic transplant. Whether we get paid extra or not, that's another story, right? But yes, it is true, it is more expensive now. But think about it. Think again about laparoscopy. In the past, it was all open. All you need was instrument, right? All your instruments showing. That's it. Now we're doing laparoscopy. I could give you the same argument 20 years ago. Why would you use laparoscopy? Is you pay the same if you get open or lap. And then, why? But now, because it's already included in the cost. So in the future, what's going to happen with robot is just going to be another tools. So whether you want to do laparoscopy, you want to do robot, you want to do open, doesn't matter anymore. You do what is best you think for your patients.
Lo que dijo que para la institución, si haces 350 casos de lo que sea por año, salís hecho. Hecho. Empezás a ganar plata después. Es decir, si vos tenés, lo amortizás. 350 casos por año de lo que sea, prostatectomía, hacen nefrectomía, parcial, todo. 350 casos por año, la organización sale hecha. Aparte, si haces 400 ya empezás a ganar plata. Y tenés 350 casos, no trasplantes, casos. Entonces, por ejemplo, meter una organización grande compra uno, tiene que tener cirujanos generales que sepan sacar, que sepan hacer la colecistectomía, que sepan sacar cáncer de colon, que hagan prostatectomía, que entre todos hagan 350 casos. Es decir, no te alcanza con una sola especialidad, tenés que tener muchas especialidades quirúrgicas que sepan usar el robot, ¿no? Sí.
Con los robots podemos reemplazar a los cirujanos.
¿Cómo?
The respuesta, they said that this robot is going to replace us at the surgery.
It's possible.
Surgery, right?
Yeah, that was easy. They did a HIFU. They did the HIFU, you know, for ultrasound, high intensity focus ultrasound for prostate, right? What we did, what Laura is saying, we did a HIFU. The doctor is in Cleveland Clinic, and then the machine is in Abu Dhabi, and we're able to, and I don't know how they did the control, but I'm sure they control, I mean, perhaps it's just a Wi-Fi, you know, it's just, I mean,
tenemos hospitales en Florida, tenemos hospitales en Londres y tenemos un hospital muy grande en Abu Dhabi. El cirujano operó desde Cleveland con un robot, hizo una, ¿qué digo? ¿De prostatectomy?
No, HIFU, no, it's just an ultrasound, it's just like a, it's like an ultrasound, they just put it there, then the ultrasound will shoot the ultrasound to the prostate.
Claro. Le hizo un procedimiento intraprostático desde Cleveland, el paciente estaba en Abu Dhabi.
I mean, I don't know
remotamente lo hizo con el robot.
hoy en día domingo
el paciente está allá y el cirujano estaba en Cleveland Clinic en Cleveland y lo hizo remotamente. So you can work from home.
I can work from home. I can work. But Domingo, you are right, because I don't know if you saw that. You know, when they were talking about robot, Elon Musk sent a tweet, right? I don't know when was he sent a tweet. He said in 5 years, he said Cinco, in just 5 years. That was just 2 months ago. Whether it's true or not, I don't know. He said in 5 years, even the doctors, the surgeons, he said surgeon. I don't know what case was that. Somebody was showcase about some operation, and then Elon Musk sent a tweet. He said, yes, this is great. In 5 years, the surgeon will be replaced by the robot. That's what he said. I mean, whether it's true or not, we don't know.
For Elon Musk, we are living on Mars today.
Yeah, that's true. So if that happened in the United States, I'm coming back to Argentina.
Okay.
I have a job here. I have a job here in Argentina for another 5 years before all of us go into
Ahora, nadie se
robotics.
pregunta si los robots pueden reemplazar a los nefrólogos, ¿no?
No, esa no es.
Ah,
No, la pelea,
Inteligencia artificial, sí.
hay una pelea muy grande hoy en día con el uso de la tecnología.
Ayer contaba que ahora en Cleveland Clinic compró un software de inteligencia artificial que es dedicado a medicina solamente y que ahora nos obligan, just like they are making you do the
Yes,
robot,
yes,
they are making us see patients with inteligencia artificial. Entonces nos están ahora obligando a que tengamos por lo menos un número mínimo de casos por mes. Laura, ¿vos ya lo hiciste al tuyo o no? Te van a seguir mandando correo electrónico, yo ya lo hice. Donde usamos inteligencia artificial ahora para ver pacientes. Es decir, el paciente entra, lo activamos, hacemos una conversación con el paciente, como entrevistar, y cuando terminás lo apagás y automáticamente la computadora genera la historia clínica entera, en orden, la acomoda todo. Vos podés empezar, me duele el dedo gordo, después podés decir que me fui a comer sándwich con mi sobrino y después volver a contar y acomoda todo, ¿entendés? Y después al final te hace la impresión y el plan y te recomienda qué le falta al paciente. Por ejemplo, un diabético que le falta un inhibidor de la... Te dice, este paciente tiene todo esto, el diagnóstico diferencial, esta es la recomendación. Al final del día estás vos en que decís que sí o no. Yo ya lo usé varias veces. Lo que no me gusta es que escribe mucho y yo soy muy cortito para escribir.
I think, Emilio, you need to mention to them that we used to use Scribe. There was a medical student who did all this for us, but now they remove all the
desde el
Scribe.
2003 que tenemos, ¿cómo se dice esto? Historia clínica electrónica, que yo perdí no sé escribir más, me sale la caligrafía, porque no usamos lápiz, hace 20 años no uso lápiz.
Yeah.
Y teníamos, en un momento, antes teníamos un
Scribo. Scribe,
sí,
right?
un escriba.
Scribo, right? Scribe.
Alguien estaba al lado que nos escribía, nos tipeaba para nosotros, para los viejos, y nos tipeamos rápido. Y ahora lo reemplazaron todo con inteligencia artificial. Así que ya a lo que voy, IA may replace the nephrologist.
I don't know.
Reemplaza la inteligencia
that's what they said. I don't know.
Ya la estamos usando cotidianamente. Cuando vaya los próximos 10, no sé, con Gador, van a verlo cómo lo utilizamos.
Yo también.
Yo creo que en el futuro la diferencia de calidad entre los médicos se va a basar quién tiene el mejor inteligencia artificial. Porque inteligencia artificial hay varias empresas que producen. Entonces, el médico mejor va a ser el que tiene mejor inteligencia, la maneja mejor.
What did you say?
Best doctors will be the ones that have the best AI.
I think so. I think so.
Well, to finish it, thank you again, Alvin, for finish this conference. Thanks, Alvin. You are amazing.